It's time for DocTalk Radio, brought to you by Gilbert Hospital and Florence at Anthem Hospitals. I'm Dr. Ann Borik, board certified in internal medicine, and I'm here to keep you up to date on the latest information pertaining to your health and well-being. Welcome to DocTalk Radio, sponsored by Gilbert Hospital and Florence Hospital at Anthem. Today, Joe, how are you today?
I'm really good today. Thank you, Dr. Borik.
Well, it's just me and you in the studio today, and there's a lot that I want to go over. You know, people who watch the show know that we have a guest, you know, on occasion.
Right.
And usually we talk about the topic of what their specialty is, whether it be cardiology or podiatry or dentistry or whatever. But today what I want to do is really kind of open it up. Obviously we want people to call in, and that number is 480-745-1033. But I want to talk from a perspective of my background, which is internal medicine as a hospitalist. And I'll talk a little bit about what hospitalist medicine is, and really the top diagnoses that I take care of in the hospital. And then, you know, I really would like to go over some new research, because there's some really interesting research out now talking about nutrition and fitness and heart and all that stuff.
And today will kind of be an opportunity for people to call in with general questions rather than a specific, what do you call that, a modality?
Well, it's a specific, you know, background, I guess.
Right, gotcha.
Yeah, or specialty, I guess it would be.
There we go.
So, you know, the first thing that I want to kind of open up, and I've collected questions that people come to me with, whether it be on Facebook or Twitter. You know, all the time people are asking me, you know, what is this diagnosis or what is this? And I collect them for days like today. And so I have a whole list of questions that literally patients and colleagues and, you know, nurses and people that have come in contact with me have asked, you know, why don't you talk about this on the show? So the first thing that I want to address is something called sepsis. You know, people say, well, what is sepsis? And so I want to just kind of give right off the bat what sepsis is, because I think it's important. Sepsis is the body's response to an infection. And what happens in the body is, if there's an overwhelming infection that occurs in the body, a whole cascade of things start happening. And those things affect the body's blood pressure, the body's ability to, you know, coagulate. It affects the kidney, it affects the heart, it affects mentation, all of those things.
And this is something that dogs, I mean, anybody can really get sepsis, right?
That's true. Anybody can get sepsis, but in the human, we basically manage it with what we call pressors and certain antibiotics and things in the intensive care unit. So an infection occurs. Usually it's either an infection of the lung, an infection of the urinary tract, and then that infection overwhelms the body's immune system, and a cascade of events happen. And so when you hear sepsis, it's really the cascade of events that's happening manifested by low blood pressure, low flow state, meaning that there's not enough, you know, circulation to the kidney, so the kidney starts shutting down, the heart is affected, the lungs become less pliable and they start filling up with fluid, and we see what is called multi-organ failure. And as a hospitalist, that's the things that we take care of in the hospital. So it's a very serious thing, but I guess the message really is, you know, if you feel ill, if you feel sick, it's important to be seen by a physician, because if it's left untreated, whether it be the urinary tract, whether it be the, you know, lungs, whether it be a skin infection, that can oftentimes progress and overwhelm the body's immune system, and it can lead to, you know, bad outcomes. So just wanted to kind of put that question out. I invite you to call in, because this is really a time today we set aside for general questions, 480-745-1033. Hospitalist medicine, I want to kind of talk a little bit about that, because just not long ago, I mean, we've been practicing now, hospitalist medicine has been around for probably close to 20 years. And even today, there are people that don't know what hospitalist medicine is, because it's a new specialty.
I had certainly never, ever heard of it until I met you, Dr. Borik.
It's a new specialty. And what it is basically are physicians who dedicate their day, their time, taking care of the hospitalized patients in the hospital. Predominantly, it's a board-certified internal medicine doctor. Very rarely do we have family doctors practicing in the hospital, because the whole set of skills that we use are different than the outpatient. So
even to break it down a little bit further, an internal medicine doctor like yourself,
right,
you could still treat the family.
Exactly.
Okay.
Exactly. And there are internal medicine doctors who have both an inpatient practice as well as an outpatient practice. But hospitalist medicine is primarily inpatient driven. And the benefit of that is multifold. I mean, it benefits the hospital, it benefits the patient, it benefits the staff, because the staff gets to know the physician more intimately, better, so that if there's an emergency, they know who to call, they know when to call. There's a trust there that is built.
And for those of you listening, this show is sponsored by Florence Hospital at Anthem in Florence, Arizona, with the helicopter on the top.
Exactly. And Gilbert Hospital in Gilbert.
That's right.
In both of those hospitals, we have hospitalists dedicated 24/7. And so it really does benefit the hospital, because it gives you that specialty person who is kind of the point guard that manages the care in the hospital, so that it's effective, it's efficient, patients get in and out in a more efficient manner. Let's say I had an office that I had to go to in the middle of the day. Historically, what would happen is I would go early in the morning, round on the patient, go to my office, see a whole panel of patients in the office, and not be able to get back to the hospital. And so if the patient needed something in the day, or if a family member came in and needed to talk with a physician, oftentimes a physician is not available.
Maybe it's 5:15 once a day.
Exactly.
Oh,
or
yeah.
later in the evening, after hours.
And that's how I thought it always was.
It is.
I didn't know it was any different than that, or it could even be different.
Well, that was how it always was until hospitalist medicine really came into play. And we found that it really makes a difference, because the skill set is so different in the hospital, managing sepsis, managing the critical patient, compared to, taking care of the outpatient kinds of things that we see. And so in my own practice, when I came out of training, I actually started in a multi-specialty group. I had an office practice and a hospital practice. And I found that it was too difficult to dedicate the time that was needed to the hospital patient and to the outpatient. So I decided to really focus on the hospitalized patient. And back in probably 1997 is when we started the whole hospitalist concept and program. And at the hospital here in Florence Hospital at Anthem, Gilbert Hospital, we have not an admitting service, which some hospitalists actually say, we're a hospitalist, but they go to 3 or 4 or 5 different hospitals. We have our doctors that are dedicated just to that hospital. And I think it's very important to differentiate that. Another big topic, another big diagnosis that we see as a hospitalist is congestive heart failure. And I want to talk a little bit about congestive heart failure, because I think it's misleading in a lot of senses. Congestive heart failure is simply fluid buildup in the lung because the heart muscle is failing to pump. Okay. The muscle is a pump. The heart muscle is a pump. And really it's designed to pump blood so that it circulates through the entire body. When that muscle, for whatever reason, doesn't pump as strongly as it should, fluid backs up in the body. Fluid backs up in the lungs. And that's what we call congestive heart failure. Now there's different types of congestive heart failure. There's something that we call systolic, and there's something that we call diastolic. And simply what that means is the phase of the heart pump time. So for example, systolic heart failure is related to the actual muscle in the contraction phase not being as strong as it possibly can. Diastolic congestive heart failure is when the relaxation phase doesn't relax completely, and as a result doesn't completely fill, leading to a decreased output. And so if you think of the two, I can give you a whole list of reasons why people go into congestive heart failure. Sometimes medication can reduce the pump of efficacy. Sometimes medications can blunt that effect. Sometimes decrease blood flow to the heart muscle, for example, leading to a heart attack, or people that have coronary artery disease. Sometimes diabetics who have decreased blood flow to the heart muscle can lead to weakening of the heart muscle, which ultimately translates into congestive heart failure. And so even stress can do that. We know that there's something, not long ago on the show we had a cardiologist talking about broken heart syndrome, where stress in the body, whether it be, a loss of a loved one or, a loss of a job, some stressor stuns the heart muscle where the muscle doesn't work the way that it should. And as a result, simply the fluid backs up. And the way we treat that, there are different things that we do to treat that. Number one, we treat with diuretics to get rid of the fluid, the excess fluid that's not being circulated and pumped out. Another way to treat congestive heart failure is to give medications that strengthen the pump action of the heart muscle. And a lot of times we use the two in conjunction. You're on a diuretic, plus you might be on something that actually helps strengthen the heart muscle. And so those are the kind of things that we look at in the hospital when people come in. The message that I often try to give my patients is education about the disease process so that they don't end up coming back to the hospital. And probably the most important point that I can tell you about congestive heart failure is to manage and monitor your weight. Because if you start gaining weight, that tells you that you're gaining fluid weight. If you notice swelling in your lower extremities, that's a trigger. That's a tip-off to say, well, maybe my heart muscle is not functioning the way it should if you have a history of congestive heart failure. And a lot of times we manage that on the outpatient. Your doc will say, well, take an extra Lasix, for example, or, whatever the case may be, or come into the hospital or call your doctor when you see a 3 to 5 pound weight gain, even though you're not feeling symptomatic, because we can get ahead of the game before it gets bad when you have to come into the hospital. So those are kind of some things to think about in congestive heart failure that we see in the hospital. George, you have a question?
Yes. We had Juliana from Gilbert, Arizona, who said, I have chronic bronchitis. I always have a hurting slight burn when I breathe. My primary doc says it's normal with chronic bronchitis. Is this true, or should I come to your hospital for a second opinion?
Well, that's an interesting question, Julie. First of all, the hospital is not really designed to come to as a second opinion. The hospital is more as an acute care facility for people that need to be admitted more on an emergent basis. So the question is, do you want to seek out a second opinion as an outpatient? And that's a hard call. I don't want to diagnose anything over the air. However, chronic bronchitis, a lot of times we need to find out what is the trigger. Why do you have chronic bronchitis? Do you have underlying emphysema? Are you a smoker? Or is there something else going on in your body that, that there's some deficiencies that, that people kind of have hereditary conditions that can lead to chronic bronchitis. So those are some of the things that need to be figured out. And what I oftentimes recommend, especially during the flu season, people who have chronic, and I mean really bad lung disease, who get recurrent infections and bronchitis time and time, maybe 3, 4, 5, 8 times in a season, what I would recommend is to take an antibiotic maybe for 1 week a month as a prophylactic, as a preventative, to kind of help keep that infection under control.
So I have a question on this one.
Okay.
And people out there may wonder the same thing. If you take an antibiotic, and I'm sure I'm probably totally off base,
right.
If you take an antibiotic once a month for a week, does your body get immune to that?
Yes, you can. However, if you have recurrent infections, and you basically have underlying COPD, for example, and you've been on steroids and your immune system is down, it's that subset population that this really, really works well, and there's a lot of research to back it up to show that actually helps keep people out of the hospital. But you're absolutely right. We have to be very cautious not to overuse antibiotics, because if you do use antibiotics when they're not really necessary, you develop a resistance, and that's not good.
And is it important, Dr. Borik, to make sure you're not using old, outdated antibiotics?
That's definitely taboo. I would not recommend anybody taking any medication, whether it be antibiotics, whether it be seizure medications, heart medications, thyroid
pain pills,
any kind of medicine that is outdated. Because what happens is it can become toxic to the body. The body actually, when it breaks it down, it can actually end up staying in the system longer. And that can lead to bad problems.
And just for those of you, I see our phone lines are just blinking left and right here. I know they're lit up. what I'm doing is I'm taking a couple of calls, turning the phones off, then I'm going to get right back and grab the phone line. So, guys, just keep calling in. Just if you're calling and it's ringing, just hold on. I'll be grabbing the phone shortly. One more question, I'll get right back to the phones. This would be from Roseanne in Santan Valley. Where is the Florence Hospital located? Just located out here to Santan Valley. I go to the hospital quite a bit for some conditions, and I've been going to a different hospital, but I want to go to a hospital where there's a hospitalist.
Fantastic. You know, the Florence Hospital at Anthem is located on Hunt Highway. Joe, do you have the actual address? I know that it's...
I can get that quickly.
If we can get it. It's right on Hunt Highway. I want to say just west of the Anthem, Merrill Ranch at Anthem. It's a beautiful facility.
There's really no way to miss it if you're driving down Hunt Highway towards Florence. Or towards Anthem. Mm-hmm. Look for the big helicopter on the roof, but I'm going to get you the exact address right here.
It's a beautiful facility. It's 38 beds. We have the entire inpatient wing of the hospital. Each room is a private, very spacious big room that is what we call a MOSU. It's a multi-operational kind of a room where if you, for example, need to be transferred to the intensive care unit, we don't move you from your room. The room actually gets converted into an intensive care room. It's state of the art. I mean, it really is a beautiful facility. It's an honor to work there. We have a great staff.
And this is an amazing time that Julianne called in, or Roseanne called in, because of the ribbon cutting.
Joe, I'm glad you said that. We have a ribbon cutting. So Roseanne, I would love to meet you. Why don't you come on over? It's going to be on Wednesday, December 5th from 11 to 1. And the ribbon cutting, is really, when we opened the hospital, this was in March, the hospital opened, we got started, and really didn't have a grand opening because it happened, so quickly, and they really wanted to wait until the winter visitors were back in town, because in March we were heading into spring and summer. So now we're kind of, getting things together and really going to open up, and would love to meet the community. We have a big outpatient diagnostic center as well, which really is unique. And I want to kind of comment about this both at Florence Hospital as well as Gilbert. Anytime, 24 hours, you can come in. If, let's say, you need to have blood work done, or you need to have your cholesterol checked, or you need to get an X-ray for whatever reason. A lot of the diagnostic centers are open, from 7 a.m. to 6 p.m. or 7 to 7, and you may be working, you may not have time to wait. At our facility, we decided, Dr. Johns and David Wenger, who's the CEO, who just does a fantastic job, decided that, we want to, this is your hospital, this is your community hospital. So, there's no reason to make it where it's inconvenient. So if you need to come in and get testing done, diagnostic testing, you can come in at midnight, for example, and get whatever tests you need done on an outpatient basis. And not a lot of places do that. And so I just want to make sure that people hear that. The address is 4545 North Hunt Highway in Florence, Arizona. And again, it's called Florence Hospital at Anthem. And our sister hospital is Gilbert ER Hospital. One of the things that kind of sets us, along with the hospitalist, and right now, a lot of hospitals have hospitalists, but my understanding and my experience has been that a lot of times they go to different hospitals, and sometimes that can defeat the purpose. If you say, we're going to be a hospitalist and I'm going to dedicate my time to your hospital, but then you go to 3 other hospitals and you're not in the facility, that doesn't lend to really the efficiency that, that we're saying we're providing. And I guarantee you at Florence Hospital and at Gilbert, we have a staff of hospitalists that are dedicated, to that facility. We're not running back and forth. So I think that's, important to know. So I know there's a couple questions coming up that we'll be talking about, but please don't hesitate to call. And this is just a day that I wanted to, put aside. We usually have guests focusing on specific topics, but today we wanted to open it up from internal medicine. A question that comes up and has come up to me many times is, does dental problems, poor dentition, cavities in the mouth, does that have anything to do with leading to other medical conditions? And I want to tell you that, yes, it absolutely does. There's research now showing that dental caries, poor dental care, actually leads to a higher incidence of coronary artery disease. And I think that's really very, very important. And we're finding that there's some other, other research that's really backing up the connection and the systemic effect that poor dentition has in cavities and poor dental care, gingivitis and those kinds of things that can lead to other physical problems. We're going to have a dentist on the show in a couple weeks, and we'll talk about some of that stuff. But I think that's important to realize and recognize. You have a question, Joe?
I do. This is an interesting sounding question here. Rachel from Tempe, first of all, wants to know: is there a hospitalist in Gilbert?
Absolutely, there is. Yes. That's our the core. That's the place that we started, and so we have 24/7 coverage at Gilbert ER Hospital.
That was very important to Rachel, and she said, "Is that Gilbert Mercy Hospital?"
No, there is a Mercy Gilbert Hospital. The hospital that we're talking about here is Gilbert ER Hospital on Power Road, with the helicopter on the roof. It was really coined the phrase "door to doc in 31 minutes." And so, the hospital really was opened and is owned by a physician, by an emergency room doc who, by the way, I've worked with for years in the Chandler Mercy Gilbert system, and decided that, the wait in this area is just unbelievable. Sometimes people are waiting 12, 14, even 24 hours in the emergency room. I mean, I remember, Joe, having to transfer a patient from the hospital that I was in years ago to Utah because there was no bed in the valley. And so because of that, we thought, what we really need to do is focus more on the emergency room and make it so that when people come to the ER, we get them in a very quick manner. And so how they do that is they staff it in a different way than most other hospitals staff it. So you come into the emergency room at Gilbert ER Hospital or Florence Hospital at Anthem, and the mechanism of how they take your information and get you into the emergency room is much different than if you went into, one of the other hospitals in the area that doesn't focus on that specific area, which is the emergency room. And because of that, we basically don't have an ER wait. You may go on the website.
It's amazing.
You know what? It really is amazing. And I don't know that I've really seen more than maybe 2 people at a time ever. In fact, we talk about it and we laugh about it in meetings at the hospital, where that's wasted space. The waiting room in our hospital is wasted space because people don't wait. Now, it's not because we're not busy, because honestly, we are very, very busy. But it's efficient. And when you focus on that and you staff for that, then those are the results that you see.
Let's get to Rachel's question now, and thank you, Rachel, for being patient, and thanks for those other questions. Those were very good. Mm-hmm. Rachel says, I notice when I press my finger into my lower legs, and this is a new thing, an indent stays. I'm not feeling terrible, just a bit under the weather, but it makes me nervous. Should I go to a hospital and get checked?
Okay, that's a really, really good question that's going to lead to some general information that I want to give. So, Rachel, thanks for calling about that. What she's describing is what we call edema. And I'm sure people have heard of, lower leg swelling or edema. Now, my first question is going to be, does it happen on one leg or does it happen on both legs?
She said it's both legs.
Okay. The reason that I want to know that, if it's one leg, let's talk about one leg and then I'll talk about both. If it's just one leg, that would tip me off to think that there's something going on in that one isolated leg. Like, is there a blood clot going on, or something like that. So in Rachel's case, it's not just one leg, it's both legs. If people who are listening have that same symptom in just one leg, my answer would be yes, you should be seen in the emergency room to make sure that there's no blood clot. So the message is, if you have swelling in one leg that is new, where you have calf tenderness, where there's some redness, particularly if it's aligned with the history of you recently going on a long trip or being immobile or less active, then the chances of a blood clot being in that leg are possible. And the only way to know whether or not there's a blood clot there is to go to the emergency room Your doctor's office usually is not able to do that. We see a lot of people being sent in from doctor's offices to the hospital to get a Doppler, to get an ultrasound to make sure there's no clot. So that's the one-sided. Now let's get back to her question, which is in both legs. A couple things. Do you feel short of breath? Are there symptoms to go along with that swelling? If the answer is no, then the congestive heart failure that I talked about earlier probably is less likely, because the manifestation of congestive heart failure causing swelling is that the heart muscle doesn't pump, fluid builds up, and you develop this swelling, and when you press on the leg, the indentation stays. That's what we call pitting edema. But there's a lot of causes of pitting edema. Congestive heart failure is just one of them. Doesn't sound like she has congestive heart failure because there's no other symptoms that go along with it. So the other question is, well, is there a thyroid issue going on? Hypothyroidism, which is an underactive thyroid, can lead to pitting edema, because what happens is when the thyroid gland is underactive, every metabolism action in the body is slowed down. And so people tend to gain weight who are hypothyroid. Skin becomes very dry, they become sluggish, fatigue, constipation, and swelling, because things don't move through the body as quickly as they should, because like I said, everything is slowed down. So that's another thing to think about. Is there hypothyroidism? Another thing to think about, in Rachel's case with pitting edema in the lower extremities, is there just fluid overload? Is it maybe that you're eating too much salt? Is it around the time of a female's menstrual cycle where you just tend to retain fluid a little bit more? And that's possible. The other thing is sometimes if people, and it's amazing how many people are out there that are malnourished from a protein standpoint. We see a lot of people going on these crash diets, these 500-calorie diets that just eat fruits and vegetables but no protein. When the body lacks protein, what happens is we develop what's called third spacing, or fluid tends to seep out of the tissues. So in the hospital, when I see people, we do a blood panel, and I see that the albumin is low, or the protein level, which is the albumin, oftentimes we see that there's edema, that there's third spacing, and there's fluid buildup because of that. We treat it, and the way we treat it is to give protein or albumin and force a diuresis so that it brings the fluid back into the vessels, and then we get rid of it. So that's kind of a trick that, as a hospitalist, that we use. So I want to get to where at least people can understand what I'm saying, but it gets very complicated. But yet I'm trying to make it as simple as possible. But when you think about it, it makes sense.
So really, breaking it down to a layman's standpoint, being that she's just a little under the weather, but sees those indents and is kind of nervous about that, should she see a primary care doc?
Probably. Yeah, primary care doc.
At least at first.
Absolutely. In the hospital, particularly as things start, down the pike, who knows how, the whole healthcare system is going to work. There are certain diagnoses that are not indicated for the emergency room. And I think we're going to need to kind of put things back in balance where there's, outpatient things that can be taken care of as an outpatient in the doctor's office, and not really go into the ER. And this would be one of them. To go to the emergency room with a little bit of swelling and not feeling well, that probably can be taken care of in a doctor's office. And the reason I say that is because down the road, they may deny payment. Your insurance company may deny that. Now, we will see you. The hospital doesn't deny anybody. But I just want to make sure that I'm not giving a message that anybody should go to the ER for anything, because you may be affected in a bad way where you may not get your insurance covered or in those kinds of things. So I would just be aware of that.
Gotcha. And I just wanted to say this show is sponsored by Gilbert Hospital, Gilbert ER Hospital on Power Road with the helicopter on the top, and Florence Hospital at Anthem, door to dock in 31 minutes.
Right. Another thing, Joe, that there's a lot of research coming out. Just recently in Chicago, they had the National Research Conference talking about physical activity, osteoarthritis, and those kinds of things. And for the first time in the history of treating osteoarthritis of the knee, exercise now is actually a prescribed modality for osteoarthritis of the knee. And so people listening out there, that's huge. We're seeing now that, meditation is becoming not only something that we know helps, but it's actually being prescribed by the medical community for certain
just to relieve stress and
stress. In this case, exercise is helping with osteoarthritis of the knee because it strengthens the integrity of the entire knee joint, and that makes a difference, strengthening the muscles and those kinds of things.
And we do have a question from Jonathan out at AJ, but I did want to say, if you're out there listening, and you like what you hear and you're going to be a regular on the show, please go to Facebook and send a friend request out to facebook.com/ or / I'm not sure which one that is, Doctor, that's DrAnne, ANNE, Borik, BORIK, or go to Facebook / DocTalk Radio and like it. Of course, you can go to the hospital's websites and like those. I don't have those written down in front of me, but let's start with that, and we're going to move forward because, the Florence Hospital at Anthem is in a place located a little bit rural. But you know what? It's worth the drive for the hospitalist medicine. So we thank you for listening, and let's get to Jonathan's question here. It says, I have the flu. I've been through Keflex. Still have the flu 3 days after. I'm having tightness breathing, and I feel like I'm getting worse. That's Jonathan from Apache Junction.
Okay, I don't know how old Jonathan is, but Jonathan, thanks for the call. What that brings up that I would like to bring out is that the flu is something that, no matter what we do, has to run its course. And so I wouldn't expect for Keflex to really help it. No matter what we do, 7 to 10 days is what we know that the flu runs its course. Okay. Sometimes, there's some research talking about vitamin C, echinacea, those kinds of things. Not a whole lot of documented evidence about that, but sometimes that can shorten the course. But, with the flu, it's just a matter of rest, staying hydrated, making sure you get fluids. That would be a reason to come to a hospital, is if you're not able to keep things down. If you're dehydrated, if you have vomiting, if you have diarrhea, that is an absolute indication to go to the emergency room, because IV fluids is something that would need to be given. With wheezing and tightness in the chest, instead of Keflex or another antibiotic, maybe an inhaled dilator, a bronchial dilator, like albuterol or something like that, just in the short term, because it sounds like you probably have more of a like a bronchitis associated with it, where you have the tightness in the chest and so forth. So those are the things that we would recommend. Do we treat the flu symptoms and so forth with antibiotics? We do. A lot of times, your doctor who probably prescribed the Keflex, feels that sometimes, even though you have the flu, you can develop a super infection, like a bronchitis that turns into more of a bacteria. And that's why we treat with the antibiotic, to prevent that. But honestly, no matter what we do with the flu, it has to run its course. Right. In Arizona, valley fever is something that looks like the flu. And, a lot of times you can get a febrile illness, fever, chills, sweats, cough. Oftentimes it runs its course and then it gets better. It's what we call self-limiting. But valley fever can be a pretty serious thing. If it develops into a pneumonia, it can become systemic. And I got to tell you, I want to share a case that I actually have in the hospital not long ago. I had where a young guy came in with chest pain and was admitted through the emergency room, because chest pain is absolutely a reason to go to the ER. Because if you sense or you feel that you're having a heart attack, do not pass go straight to the ER. And then they can do a workup and determine whether or not, is it cardiac or not. In any case, this young guy came in, was admitted, ruled out, did a stress test, everything looked great from a heart standpoint. But in doing that, there was a couple things that we noted in the lab work. And one of the things was that there was an elevated, what we call D-dimer. And that kind of gets the attention of the emergency room docs as well as the hospitalists, because a D-dimer, which is a blood test, oftentimes can be elevated when there's a blood clot in the body. And so the ER doc at that time immediately did a CAT scan to rule out a blood clot. And I'll talk about blood clots in a minute. So anyway, blood clot was ruled out, but on the CAT scan there was this extensive, what we call lymphadenopathy in the lung, both sides, and there was actually a mass that looked like a tumor. Now, when I see that, I get nervous because, you know, obviously if there's a suspicion of cancer, we want to get an answer and we want to get it taken care of. So this guy basically, young kid, young guy, rolled out. We discharged from the hospital. I conferred with the cardiologist, and the cardiologist said, you know, let's get this guy followed up immediately. So to make a long story short, I saw him in follow-up because he didn't have a doctor to follow up with. And immediately we set him up and we did a biopsy of that mass, of that tumor. And that's the other thing, that at the hospital, I mean, there's no wait. We literally did it that same day. Everything was done like within 24 hours. And so biopsy was done, and boy, it looked, the way that the radiologist called me up and said, you know, I'm really suspicious that this is cancer, you know, and I said, yep, we got it. Everything is under control. You know, he's getting a biopsy. Well, the biopsy just came back just a couple days ago. And lo and behold, it was a necrotizing coccidiomycosis, meaning that it was a fungal infection from valley fever. And when I saw that, I was actually very relieved, because the other alternative would have been, you know, a cancer. So the point is that valley fever usually runs its course and, you know, there's no effects. However, sometimes it can cause a mass, sometimes a biopsy is needed. In this case, you know, he did great. We literally got an answer back, you know, within, you know, a very, very short period of time. And those are the kind of things that we can do at Gilbert and Florence Hospital. You know, we do a needle biopsy. We can get it in, get it done. I think he had it done like at 7 o'clock that night, because when I saw him in the day, he said, I don't want to wait. So we got him in and we got it done, and it was a good outcome. You have a question, Joe?
Sally from Mesa just wanted to comment. She's never been in a hospital for less than 6 hours, so she's very excited about the hospitalist thing.
Okay.
But her question is, I've had valley fever for 7 years. For about the past year and a half, I've had lower back pain behind the lung sporadically, and it kind of scares her, but her primary care physician says, oh, don't worry, that's normal with valley fever. She says, is there anything I can take over the counter, herbally? Should I go to a hospital? Should I get a second opinion? I just don't want to...
Yeah, I mean, was she diagnosed with valley fever?
Yes.
Okay. You know, having the diagnosis of valley fever, I would not hesitate getting an x-ray, a follow-up x-ray. Because as I just told you in this particular, you know, guy that we took care of, sometimes you can develop kind of a locked-in pneumonia, you know, or even sometimes it's not even pneumonia, but even like a little abscess or something like that that can be in the lung, that if you don't look for it, you're not going to find it. With your history of valley fever, I think it would be warranted to get an x-ray.
That's just all the time irritating and hurts a little. And
you know, it's not going to hurt to get an x-ray to make sure.
Wow.
With the history. Now, do I think it's anything? Probably not. I think it's probably muscular. I think it's probably safe to take an anti-inflammatory that'll help with the inflammation. You may have a little bit of pleurisy there. Make sure that you do some deep breathing. You know, when you go to the hospital and you get that incentive spirometry, the little machine where you suck in and the little ball goes out. You know, we do that for a reason, because deep breathing oxygenates the lung. It expands the lung, and it really kind of helps to clear out the lower part of the lung. Because when you're a shallow breather, as most of us are, the bottom parts of the lung tend to collapse in on themselves. And so over time, if you're not aerating that, then you're at a higher risk of setting up an infection. And if you've already had valley fever or pneumonia or something, and you don't breathe deeply, then chances are you're not going to get rid of that. And that's why it's important to do deep breathing exercises. An x-ray probably wouldn't be a bad idea, but you may want to just try, some heat on the area, treat it more muscular, anti-inflammatories, those kinds of things first.
Wow. And the way to send a friend request to Dr. Ann Borik is facebook.com/Dr. DRANNE BORIK. Love to have some new friends. And as I understand, Dr. Borik, you're going to start putting some... Dr. Borik does a daily blog, which I absolutely love. I learn things every day. I feel like a doctor when, after a year of...
you're going to be tested, Joe. You don't know that.
I hope so. I hope so. But, go there or go to DocTalkRadio.com. You go there to check out the show, or, of course, KQCK, and make sure you like that page. Charleston, South Carolina, Milton Says, I'm a type 2 diabetic in my 50s. In the morning, I notice my blood sugar's between 130 and 170, but when I take my pills, it goes down to normal. Is that acceptable, or should I consider getting on a more aggressive therapy?
Great question. Over 30 million people are diagnosed with diabetes in this country. You know, in your 50s, Milton, type 2, it's an epidemic. And the message that I want you to hear, and people listening, is that it's not acceptable today, because we have some great treatment modalities, to undertreat diabetes. First of all, we know that diabetes really can be effectively treated. And there's no reason to settle for anything less than ideal glycemic control, ideal blood sugar control. So, you know, your sugars are 130s to 170s, that's out of control. You know, ideally, you want that sugar to be 70 to, 120. And so whatever it means to do that. And sometimes it's not necessarily even taking more medication. A lot of times it's lifestyle changes. You know, maybe drop an extra 5 or 10 pounds. Adjust the diet a little bit. Exercise is now, becoming more and more a modality for treatment rather than just recreation. And so, if you were my patient, 130 to 170 is not going to cut it. So there would be some other things that I would want to make sure. Is there stress? Stress, we know, affects blood sugars. So, maybe, getting into some kind of a stress relaxation, class, or, there are different things that you can do rather than, adding insulin or adding medicines to the mix. But, diabetes is something that, if you don't have diabetes, I'm sure you know somebody that does. It literally is an epidemic, and we're seeing people for the first time in the history of medicine diagnosed at a younger age. For example, before, type 1 diabetes was really the type of diabetics that we saw in kids, which is the more genetic, hereditary. And type 2 was really reserved for adults. It was considered the adult onset. But now, because of the diet, because of children that are less active, and obesity in childhood, we're seeing type 2 diabetes manifest in like 8-year-olds and 10-year-olds. And so, when you think about it, now they have their whole life to live with this diabetes that can be really destructive to the vessels. Why is diabetes such a problem? It's not necessarily the sugar. That's not really why we're treating. What we're treating is to prevent the high sugar that circulates in the blood vessels from causing a layer or a lining in that vessel, causing hardening of the artery. And that's why in diabetics, the things that we want to look at are the organs that are affected by very small vessels, like the eye. As a diabetic, we want to preserve your eyes, and that's one of the first things that we want to look at. Because uncontrolled diabetes with sugars of 130 to 170 absolutely is enough to affect the circulation to the eye. And once that happens, it's irreversible. There's no going back. Other small vessels would be small vessels that feed the kidney. And that's why, the kidney is something that we see people who have, diabetes that are out of control over years end up on dialysis, because the kidney basically is starved. It's almost like there's no oxygen, there's no circulation, because the very small vessels that feed the kidney are affected in diabetes. When you think about it, it's really a matter of size. You start out with the heart, and then the aorta is a big artery, and then it goes out into the rest of the vasculature. And by the time you get to your feet and your fingertips and your kidneys and your eyes, those vessels are so small that that it gets clogged. It gets clogged with the the glycemic effect of the high sugar circulating through the blood day in and day out. And that's why we've got to be very active with treating diabetes. Exercise is very important, because exercise keeps the blood circulating. Movement is medicine, and I've said that many, many times, especially in diabetics. It makes sense when you think about it. But that's a really good question from Charleston. Joe, you have some more questions there.
Yes, and I appreciate all the local calls. We are getting some out-of-state calls, but a lot of local calls today, and that is fantastic.
Yes, it is. That's great.
Roger B. from Phoenix. I notice I get a lot of headaches. 6 months. This has been for 6 months. They're above my eyes, and I get them every day. My doc gives me Flonase for sinus, but I don't feel like I have a sinus problem. They're really bad.
Okay. I can understand, Roger, why your doc would give you Flonase, because above your eyes, what's there? The sinus is there. The frontal sinuses are there. So that would be the most likely cause of, chronic headaches above the eye. Sinus would be the number one thing. And you may not feel that you have, sinus because, your nose doesn't run and it's not stuffy, but yet there's air cells there right behind the, like the upper eyelid area, the eyebrow. And if that's what the pain, that's where the pain is, then chances are it's sinus. However, that doesn't mean that, there are other things that can cause headaches. Tension headaches, usually at the back of the neck, usually muscle. Can you get it above the eye? You can't. The other question that I would ask is, have you had your eyes checked recently? Because if your eyes need examined, and you're squinting and you don't realize it, it's kind of like an involuntary or subconscious thing, that can put just constant strain and stress of those muscles in the frontalis area of the forehead, and that can cause pain. So that's pretty much. It doesn't sound like a migraine to me. Chances are it's either more of a tension type. Sometimes we have what's called a cluster type headache. Usually cluster headaches are associated with tearing of the eye, usually one-sided in men. But I think your doc is probably not too far off in terms of the Flonase. That's something that that we would try. So anyway, that's probably the things that I would do. If it persists, I would maybe think about seeing your doc. Maybe pursue some other things. Maybe an X-ray of your sinuses would be a good idea to see what's really going on there. Maybe a CAT scan at some point.
You run into people all the time and they say, "Oh, I have a migraine."
Mm-hmm.
Migraines aren't migraines when you have to lay in bed with the lights off and any noise wants you would just want to pull your eyeballs out.
Not really.
No?
Not really. I've actually had people admitted into the hospital as well as the outpatient, where they have a migraine variant but no headache. So we can actually see somebody that can present with like stroke-like symptoms, feeling like they can't get the words out, or numbness and tingling or weakness on one side that then goes away. They come into the hospital thinking that they're having a stroke, no headache, right? Maybe a little bit of blurriness in the eye, and really symptoms that are kind of consistent with a TIA or transient early possible stroke. They come into the ER, we see them, scans are completely normal. And as we're talking more and getting more history, because honestly, usually, our patients tell us what the problem is if we just listen, we're able to kind of connect it to some trigger. Either food being the trigger, something, in the month, whether it be a hormonal trigger. Usually a trigger is identified, and then the diagnosis of exclusion, meaning we exclude all other bad things, migraine, headache, is what we diagnose. Now there's something called a scintillating scotoma, and this is interesting because the classic headache, the classic migraine headache, is associated with a blinking, kind of a fuzzy looking, funky light display that you see in your eye, or a shadow that comes down, kind of like a black shade that comes down over the eye. It's scintillating. It's a scotoma, meaning that there's a black, shade-like effect with the vision, and that's usually something that is a prodrome, or it precedes the migraine headache, and so that's something that how we define it. And after talking to the patient, they're like, "Oh yeah, that did happen. A couple days ago there was a little blinking, didn't think anything of it. Then these other symptoms, nausea, so forth, and so the diagnosis of migraine is made." You're talking about, I just want to make a comment, because just on the Facebook DocTalk page, which we keep up to date with research and so forth, there was just a study, actually yesterday I updated it, there was a study that just came out showing that an MRI of the brain, particularly in women, shows that women who have migraine headaches, the MRI oftentimes shows white spots on the MRI. And over a year, like a 10-year study, wondering, what is the significance of the white spots on the MRI, have found really there's no significance It's something that is associated with migraine. So now we know that there's some structural changes in the brain that occur in people that have migraine.
Wow.
And that's huge, because that may lead to some better, newer modalities on how to treat migraine headache. Because really, I don't think we've actually gotten to the point where the treatment is really as effective as it can be. Because we see a lot of patients that come in with uncontrolled, migraine pain, intractable pain. Do you have another question, Joe?
Yes, we've got Pamela Cruz from Oshkosh, Wisconsin.
Oh, right.
I'm type 2 diabetic. I love diet soda. My doc says to not drink it. Does diet soda hurt my type 2 diabetes?
From a purist perspective, diet soda, doesn't have sugar, right? So I don't think that it probably has as far as I know, I don't think that there's any research correlating with diet soda, Diet Coke, Pepsi, whatever, and glycemic control. Now, regular Pepsi, regular soda would. But purely if you're looking at, the control of your sugar and the effects of diet soda, probably is not going to be a negative effect. Now, the reason that I say now is because there's some other things in diet sodas that are not healthy for the body in general. And so, that's a whole different conversation. But from diabetes standpoint, I can't honestly say that that's bad for sugar control, because it really doesn't have, the sugar. But, I think lifestyle change is the most important thing when we're talking about diabetes, and that's really kind of the message. Okay. Parkinson's is something that I'm very, very interested in. Movement, how the brain is affected. And there was a recent study out that shows that a stationary bicycle, sitting in a stationary posture, using the bicycle, has been found to help people with Parkinson's. And it's interesting, and it's not just because it's movement or exercise. It's actually the act of pedaling the cycle. And I wrote this down because it's tied to the motor function in the brain, in the area of the brain, which is where Parkinson's kind of manifests itself. And for whatever reason, the pedaling effect helps to slow down the progression of the Parkinson's. According to this study, what was really interesting was the faster you pedal, the more overdrive and the more positive effect in the motor system of the brain in Parkinson patients. And so the message really is that, if you know of anybody that has Parkinson's, early Parkinson's to moderate Parkinson's, a stationary bicycle is probably a really good idea. I mean, you can pick one up probably at, anywhere, and use it. And the message, though, is the faster you cycle, the more effective it is. And I think that's a really interesting piece of information that just came out in the research. You have a question, Joe?
I have a little bit of a disturbing, it's disturbing to me a little bit. Terry from Payson, Arizona, says, I'm a DJ and I have an 8-year-old daughter. During events, she has dropped to the floor and had what I thought were seizures, but she's come out of it no problem after a couple of minutes. I've never gone to the doc for it or taken her to the doc for it. Should I do that?
Well, first of all, what was the name, Cruz?
Yeah, Terry.
Terry, okay. First of all, I am not a pediatrician, so my medical background is for adult medicine only, 18 years and up. So, an 8-year-old is totally out of the context of where I practice medicine. However, let me just kind of give some general information. You're a DJ. My question would be, number one, are there lights? Is there like a light show? Is there something?
He said during light shows, during DJ events.
Right, that can bring out a grand mal seizure in anybody. And so it's interesting that this is actually probably a reportable case. This is a very interesting set of, case or clinical case, because if that's happening, I would venture to say that your 8-year-old daughter probably has a history of seizures and grand mal seizures, and I would recommend that you get her in to be seen by a pediatrician and or a neurologist actually, to get that treated. The reason that it's important to treat seizures is that basically seizure activity in anybody, whether it be children or adults, is the electrical activity in the brain goes haywire. kind of like the electrical activity on the heart causes atrial fibrillation or VTAC, those kinds of things. When it's in the brain, damage can occur because during that time there's lack of blood flow, there's lack of oxygen, there's lack of circulation. And so recurrently, we're concerned about, the bad side effects that, continuous seizures can have on the brain. So I wouldn't wait. I would absolutely get her in to be seen. But I'm thinking that the trigger for her seizure is probably the scintillating, the light show, the blinking of the lights and those kinds of things. That's really very, very interesting. Just along the lines of seizure, one thing that I want to make sure that we talk about from a seizure standpoint, particularly in adults, if anybody's been diagnosed with seizure activity, seizures, we're very, very cautious. And I think, I know back in Pennsylvania for sure, and in Arizona and other states I'm not quite sure, but there's a law in terms of not being able to drive if you have a history of untreated or uncontrolled seizure activity. And that makes sense. I mean, obviously we don't want, people to be behind the wheel because seizures can come on at any time. And we have some new, really good medication modalities now to treat seizure activity and keep that threshold under control. But that was a very interesting case. Joe, do you believe that the hour is...
Actually, I don't. I just looked over and I went, what the...
Yeah, it's amazing, huh?
We do have a last call here.
Okay.
Nancy from Seattle, Washington, wants to know, do you recommend the flu or pneumonia shots or the chickenpox shots, or is this a way for our government to give us population control?
Nancy, good question. I absolutely understand your concern and question. From a medical perspective, I can tell you that the flu shot and the pneumonia shot are indicated. I get them. I recommend that people that I love get them, my family, my patients. And the reason, let's talk about the flu shot for first. The flu shot is intended to boost the immune system. Basically, you get exposed to the virus. Your body, in turn, develops an antibody response. So you're basically arming yourself through the mechanism of the immunization, so that if you are exposed to that virus, and usually every season it changes, usually it's the virus that is a life-threatening virus. And so basically that's the way to protect yourself, so that if you do get exposed to it, chances are you won't, but if you do, your body will respond in a way where you may get a little sick, you may get a little head cold, you may get a little flu-like symptom, but it won't develop into that sepsis that I talked about and leading to mortality and death. People die of the flu. There's no doubt about it. Influenza, pneumonia, there's a high mortality. People can die from that. And so the flu shot is one way to keep that, personally, so that you preserve health and well-being. Now, the pneumonia vaccine does the same thing. Again, it's directed it's not going to prevent you from getting the pneumonia. And in fact, at some point, if you're in the right time, in the right place and so forth, even though you've had pneumonia vaccine, you can still get pneumonia. It's going to protect you against the most dangerous strep pneumoniae, which we know has a very, high mortality. People die from it. And what it does is it gives the antibodies, it gives your body the ability to develop antibodies to fight it. The body is an unbelievably amazing machine. And the immunizations are really intended to bring out the best in the body's mechanism.
Is it too late once you've already had the flu to get it?
No, it depends on the season. We still are giving it, we recommend it up probably through the end of December.
Let's say like myself, did I have the flu? I think I did. Is it good to get it now?
Yes,
it is.
Absolutely. Because it's not directed toward just the regular, there's hundreds of viruses that cause the flu. It's intended to be directed against the specific influenza of the season, which can lead to, bad outcome and death. So the one thing about the pneumonia vaccine is that it's recommended to be given once every 5 years. So again, the body develops this defense and it sustains it over 5 years. As a healthcare provider, we have to get immunized against the hepatitis B and C. So what happens? Well, hepatitis B vaccine, and what happens is it gives my body the ability to fight if I'm ever exposed to that. And so my antibodies have been high, and I have that protection now for over 10 years in my system. And that's what it's intended to do. It has nothing to do with, I mean, there's other government issues, but this is not one of them. This is a good thing, for all people to get. Joe, we're out of time. This has been a great show. Thank you. On occasion, we're going to set time aside for just this.
I think it's important.
Yeah, I mean, that's the whole idea. Just, again, DocTalk Radio, sponsored by Gilbert ER Hospital, Florence Hospital Anthem. The reason that we do it is really just to kind of reach out to the community and expose, some of our medical knowledge and kind of share it and really in the hopes of preserving health and well-being. And that's really what our hospitals are about, should be about, and that's what I'm about. So, and
I'm always amazed that the questions are always very good.
Yeah, we have a great group of people connected to DocTalk Radio. So stay tuned. We have some good people coming up in the next weeks to come. So we'll see you later. This concludes DocTalk Radio with Dr. Ann Borik. Till next time, I wish you health, wellness, and many blessings.
DocTalk Radio is brought to you by Gilbert Hospital and Florence and Anthem Hospitals. Topics discussed are for informational and not intended to substitute advice from your personal physician.